It is truly a great honor to come to this very beautiful city of Thessaloniki to meet old friends and to give this lecture. I have known Professor Didyangelos, Ilias Migdalis from Athens and others for nearly 30 years. So it's a great pleasure to give this lecture. So I don't know whether we have the slides. So today I had a great pleasure visiting Thessaloniki, and the history is just amazing. Visited, that's the old model that you can see here, and the rotunda here is just incredible. It's like the Pantheon in Rome. And I am also Greek Orthodox Church. I come from Ethiopia, so my parents have Orthodox. My father and my mother is Catholic, but my father is Orthodox Christian. So it was really a great pleasure coming here to learn about the history of this great city and to give this lecture. So today I'm going to talk about that we're diagnosing diabetic neuropathy very late, talk a little bit about the peripheral biomarkers, central biomarkers of neuropathy, management, and then finish with very brief conclusions. So let's start with the late diagnosis of neuropathy. I think everybody here will appreciate that we are in the middle of a massive diabetes epidemic. It is increasing by epidemic proportions, particularly in developing countries like my country, Ethiopia. It's a 200% increase almost in the next 25 years. And that is, I don't know how these poor nations are going to cope with the complications of this devastating disease. And we need to really come together and halt this tide of this epidemic of diabetes. Somehow we need to prevent diabetes. We need to change the way society. I think Thessaloniki is one of the cities that's looking into changing diabetes. Leicester in the UK is so designing cities actually to halt the progression of diabetes by having cycling paths and other and getting rid of takeaway places that have high sugar content, etc. We need really something in that avenue. Diabetic neuropathy is a distal axonopathy. It starts in the toes and gradually over many years marches upwards. And once the lower limbs are involved, the upper limbs are affected. It affects the longest nerves first, and we have neuropathic pain in around 25% of all diabetic people. It is very common. It affects 1 in 2 people with diabetes. Now in the UK we have excellent news. As of 2014, diabetes is no longer the commonest cause of working age blindness. That milestone was achieved. I mean, ever since I was a junior research fellow, I was told the commonest cause of blindness, diabetes. But that changed. Why did it change? It changed because we're detecting retinopathy early by annual eye screening using digital camera. So all patients in Britain undergo annual eye screening through dilated pupils retinal screening. Earliest changes, refer to an ophthalmologist, early treatment. That has been a game changer. It has led to a paradigm shift. So diabetes is no longer the commonest cause of blindness. Great achievement. But the same can't be said about amputations. Amputations in the UK are increasing year on year. This is from 2 years ago. Now it's 145. We capture amputations very carefully in the UK. Everything is recorded and very robust data. So retinopathy going down, amputations increasing. Why? When we look at people that have amputation, they have the worst quality of life compared to COPD, hemodialysis, osteoarthritis, diabetic foot ulcer. Those with amputation really have terrible quality of life. Amputations are devastating physically and emotionally. And mortality in amputees is 2 years after amputation. 50% dead within 2 years. If we look at the 5-year survival after foot ulcer, not amputations, just foot ulcer, we find diabetic foot ulcer actually is worse than colorectal cancer, prostate cancer, and breast cancer. So once you have a foot ulcer, your outlook is terrible, 50% dead within 5 years. And if we look at the cost of the diabetic foot in the UK, it's over $1 billion per year, and it is more than the combined cost of breast cancer, bowel cancer, prostate cancer expense altogether. And yet, we think of diabetic foot ulcers being okay. It's not okay. If you have diabetic foot ulcer, you have a big chance of death from cardiovascular disease. There is a big link between neuropathy and cardiovascular disease. So, the American Diabetes Association last year published their guideline on how to diagnose neuropathy. And what they suggested is to type 2 diabetes from diagnosis, annual screening, type 1 5 years after diagnosis. Assessment should include history, examination for small fiber function, pinprick or temperature, large fiber function, vibration using tuning fork, 10-gram monofilament for foot ulcer risk, and then if there are atypical presentations, referral to a neurologist or to do nerve conduction studies. This is their guideline. Now, this year, I was telling Professor Didyangelos that I have done 120,000 miles giving lectures in Japan, China, Taiwan, all these places, and unfortunately, this is not happening. Nobody is screening feet, even in England, annually, carefully. This is not happening, which is really not good. And in the UK, we use this implement, the 10-gram monofilament. It's like a Stone Age. So it's for like, you know, when this city was under Ottoman occupation, you know, for 400 years, you know, what you have is I was told my feet were fine on the annual check until last year when I was told I have nerve damage. Now I'm attending the foot clinic. So many patients are told, you're okay, you can feel the monofilament. But they're not okay, because the neuropathic process, when it is here, the monofilament, you can still feel it. Here, you can still feel the monofilament. You don't feel the monofilament when it is reached here. At this point, the neuropathic process is completely irreversible. You cannot, because nerves are highly specialized. They take a long time to mature, nerves. They're programmed. And once you lose them, you cannot produce them. They're not like epithelial cells, things that change every few days or every few months. And so we're giving patients a false sense of security. And then they attend the foot clinic. As soon as they come to foot clinic, their mortality is very high, 50% dead within 5 years. So we're really missing the boat. We're not making the early diagnosis. We need to change that. So what have we done about this in Sheffield? I'll tell you in a minute, but I want to show you this slide from Dan Ziegler's unit in Düsseldorf in Germany. What they did was they looked at newly diagnosed type 2 patients. When they looked at these newly diagnosed type 2 patients, and they took skin intraepidermal nerve fiber density, these little spaghettis or noodles or whatever you call them, these little small fibers in the skin, in the foot, they found actually there is significant reduction in the skin intraepidermal nerve fiber density, even at diagnosis. And if you measure sural sensory conduction velocity or amplitude, there is significant reduction. So we're missing these signals. The signals are there if we use the right test. But because we use the monofilament, we diagnose the condition late. This is some years ago now, some 10 years ago. I don't know whether Tranafolos, you attended this meeting, or Ilias, but this is the Toronto meeting 10 years ago, which I convened in Toronto, and I asked all these prominent people, including Professor Peter Dick, who's now 90 years old, still working very strong. He sent me an email a few months ago. Solomon, watch out for 2 back-to-back papers in the New England Journal of Medicine at the age of 90. At 75, Professor Peter Dick from the Mayo Clinic, he said, I'm going to stop work, so packed all his bags, went home. And his wife told me, he arrived home and he was walking left, right, you know, thinking, and he got on her nerve. And on the Monday, she took him with the scruff of the neck, said, you're going back to work. So from the age of 75 until now, he's still working at the Mayo Clinic, still producing amazing work. And so what these, if the younger members of the audience, if you've not read this paper, I would suggest you read it, because really it took a long time to write this paper, and it gives you an update on definition, how to diagnose the condition, how to treat the condition, and it took a long time to publish this, and it's been cited 1,400 times already. I would urge you to have a look at this. But this Toronto consensus suggested that symptoms and signs are not adequate to confirm neuropathy. Objective measures in addition are required, such as nerve conduction. Something objective is required, particularly for research purposes, to diagnose the condition accurately. So what we do in Sheffield is patients come for annual eye screening. Everybody attends. They're scared of going blind. But what kills these people is not their eyes, the neuropathy that kills them. They don't know that. But they're scared of blindness, so everybody attends. So when they come to clinic or community clinics, when they come, what we do is we put drops in to dilate the eyes, the pupils. Takes 20 minutes. They can't read. They're doing nothing. They're sitting down. So we use that time, that 20 minutes. We take their shoes and socks off. We do 2 tests. The first, we measure sural sensory conduction velocity and amplitude. So it takes only 3 minutes to diagnose the conduction velocity. Using this device, I know Tranafolos has this device. We have this device in Thessaloniki, I'm sure in Athens also. We also get pseudoscan. We check small fiber function. They take shoes and socks off. They stand on these metal plates, and it measures sweat function, small fiber function. 3 minutes. This one, 3 minutes. So 6 minutes. We ask DN4 questionnaire to see if they have painful neuropathy. Neuropathic pain of burning quality. It takes only 2 minutes to do this DN4 questionnaire. So 10 minutes, and then we do blood tests for A1C if they need it. Sometimes they had it done. We can check on the computer. If they've not had it done, we do all the blood tests, including albumin-creatinine ratio, EGFR, etc. It takes half an hour to do the whole thing, and they leave having had their MOT. MOT in England is like when you take your car for annual. You know, when you take your car, you don't take the brakes to one garage to check the clutch to another garage. You take it to one garage once a year. And this is exactly what we do. And the patients love it, because instead of 3 appointments, they have 1 appointment. And it's the other doctors like it because we send them the report. And this is done all by a podiatrist who also checks the feet to make sure that they don't have deformity. We also do ABPI. So in the future, this is going to include autonomic function. It's going to include brain imaging every 5 years to screen for dementia. And things are going to change the way we look at patients. So our results, which are published this year, show that we found new diagnosis of painful neuropathy. It's cut off in 25%. It's coming. If you use the monofilament, you diagnose neuropathy in 14%. Toronto score, which is detailed clinical examination, 30%. Pseudoscan, hands on metal plates, 38%. DPN check, 51%. So the prevalence of neuropathy varies depending on what technique you use. If you use nerve conduction, you will diagnose a lot more. You will diagnose the condition much earlier. We found 25% new painful neuropathy, and they're coming to our painful neuropathy service. If I can take you through this ROC curve from the paper, if you use the 10-gram monofilament test, the sensitivity is 30%. It's insensitive. Specificity is excellent, because if you can't feel the monofilament, you've got neuropathy. Area under the curve is poor at 61%. You can see the monofilament is not very good. If you look, the sural nerve action potential has sensitivity of 84%, specificity of 68%, and the conduction velocity 72%, 83%, and pseudoscan, and so on. So if you use both, you have a sensitivity of 94% to diagnose neuropathy. An abnormality in any of these three, if you take it as a diagnostic of neuropathy, you have 94% sensitivity. So really, we should move on from physical examination, can you feel these, can you feel that, into completely objective measure, which is really accurate. This is 21st century, not monofilament centuries ago. Now, some years ago, it's been how many years ago? About 2005, we published a paper, and in fact, a certain Dr. Christos Manes from this city was also an author of this paper. I don't know where Christos is today, but he's not here. I think he's retired now. What we showed is that many patients were coming to my clinic, and they're saying, Dr. S.Tesfaye, my control is perfect. My blood glucose is perfect. Why do I have neuropathy? And it intrigued me. And so we did the Eurodiab study, and it also, 31 centers in Europe, 16 European countries, including Thessaloniki. And we looked at the cause of neuropathy, the risk factors. What we found is that baseline hypertension, smoking, A1C, change in A1C over the 7-year period, duration of the obesity, triglycerides, were independent risk factors for the development of neuropathy 7 years later. So these were patients without neuropathy at baseline who developed incident or new onset neuropathy. And so we know what causes neuropathy. It's not just sugar, it is also vascular risk factors. So neuropathy is a vascular disease. It is not a sugar disease. So we know what causes neuropathy. We know how to diagnose neuropathy. Why are we not diagnosing it early and managing our patients to change their outcomes? This is a great Irish playwright, George Bernard Shaw. Many years ago, almost 70 years ago, he said, I marvel that society would pay a surgeon a large sum of money to remove a person's leg, but nothing to save it. We're happy to invest a lot of money in bypass operations, in expensive treatment for complications. But we're not happy to intensively screen patients to stop the development of diabetes itself. There's been a paper published in the Direct study, I'm sure you've heard about it, from Newcastle. 15 kilograms weight loss using low-calorie diet can cause remission of diabetes. And this is published in The Lancet. Now, in Sheffield, we're going to start that. The government is going to fund. We're going to start almost all people that are obese in the city. We're going to start putting them on very low-calorie diet for 6 weeks, get them to lose a lot of weight, and then introduce food gradually. It costs £2,000, €2,000 for the whole year to fund these. But that is the future. The future is really prevention of diabetes itself. Now I'm going to talk about peripheral biomarkers of neuropathy and painful neuropathy. So many years ago, I worked with Professor John Ward, who unfortunately is not very well at the moment. He was my mentor and somebody who really trained me, and Elias Terentaflos. Everybody knows John Ward. He was great man. And he said to me, we know what the eye looks like. We know what the blood vessels in the eye look like. What about the nerves in the feet? And he said to me, okay, I'll give you 3 years money, research money, anything you want, Solomon. I want you to show me what the nerves look like. I said, I wasn't sure if I was going to deliver. And so this was a picture from then. This is me before I developed the metabolic syndrome. In Greece, he took me for a nice lunch today. The food is fantastic. If you want to lose weight, come to England. Okay. And this is Professor Jakubowski, a Polish neurosurgeon who helped me. We did 1 patient a week. It took a lot of work to look at the nerve, at the sural nerve, which is very superficial on the ankle. And this is old style TV, but we had medical physicist, Dr. Nigel Harris, who also helped me. A lot of people participated in doing this study over 2 years. So what we were looking at was, we were looking at this, I don't know whether I'm covering you guys on this side. There's a lot of places. So we wanted to look at this nerve, this sural nerve. I'll go to this side to maybe, so you can see. So we were looking at this artery, the vein. These are the axons that you can see. These are the myelinated fibers. These are the capillaries within the nerve. And these are the penetrating arteries that supply the peripheral nerve. So we wanted to look at these in great detail. So when we took a small piece of the nerve, and I sent this to Riaz Malik in Aberdeen, if you can look, these blood vessels, these axons are damaged. Diabetes kills the axons. And then we looked at these blood vessels here. You can see this. These are the capillaries here. These capillaries here. We looked at them. Again, they looked abnormal. They were not right good. So we magnified that. So when you magnify these blood vessels, you can see a normal blood vessel. The capillary looks beautiful. Normal diabetic. If you look at a patient with neuropathy, there is basement membrane thickening, endothelial cell proliferation, with almost vessel occlusion. The center of the blood vessel is almost blocked. And what we found is that the more severe the neuropathy, the clinical neuropathy, the more severe this disease. The more severe the disease, the more severe destruction on histology. So this abnormality is clearly very important. These capillaries are important. We then looked at these epidural blood vessels and veins. I don't know whether you can see it from the back. You can see in diabetic control, there is artery and vein running parallel along the lengths of the nerve. It looks really beautiful. The artery has high pressure. The vein doesn't have a lot of pressure, high pressure. But when you look at a patient with neuropathy, there is arterial attenuation and tortuosity. The caliber of the blood vessel changing. There is no penetrating blood vessels here. Penetrating blood vessels, these blood vessels are there. But in patients with neuropathy, they disappear. And the vein, the artery joins the vein in a direct arteriovenous shunt, upon which the vein then becomes distended and tortuous because there is high pressure. Arterial blood is entering the venous circulation, causing increased venous pressure. So the big question, in fact, this was described by the first noticed by Professor Eva Kohner. She used to be a retinopathy specialist at the Hammersmith Hospital in London. She said to me, Solomon, these are arteriovenous shunts. It's not supplying the nerve, it's just going into arteriovenous shunt and going back to the heart. So what's happening is these blood vessels, these capillaries, are all blocked. And therefore blood is taking the route of least resistance because it cannot enter the nerve because these are all blocked. It's going right to the vein, bypassing the nerve. And therefore, the cause of diabetic neuropathy is impaired nerve blood flow. the blood flow in the nerve is reduced. It's like retinopathy. The same is also like kidney disease. To prove this, we injected fluorescein in the arm, and we looked at the nerve. After injection of fluorescein, you can see a normal blood vessel, a normal person. The sural nerve lights up very quickly within 30 seconds. The patient with neuropathy, the small artery, the big vein because of arteriovenous shunting, the nerve remains blocked because hardly any blood is entering the nerve. So we proved that the cause of diabetic neuropathy is impaired nerve blood flow. But many questions emerge out of this. Because what about the pain? Why do some people have terrific neuropathic pain? Others, the same degree of nerve damage, but no pain. Why? So if you look at them clinically, no difference. If you look at electrophysiology, no difference. If you look at QST, no difference. I'll show you in a minute. If you look at the biopsy, there's no difference between painful and painless neuropathy. If you look at these capillaries, no difference between painful and painless neuropathy. If you look at these blood vessels, epidural blood vessels, no difference between painful and painless neuropathy. So why do some patients have devastating painful neuropathy? What's the cause of this? Recently, this is a paper we published in 2016 together with Professor Bennett from Oxford and from Imperial College. We've been using this German DFNS protocol to look at quantitative sensory function, pain thresholds. We can measure detection thresholds, vibration, cooling, etc. And what we found is that actually, if you look at the different painful, painless, severe painful neuropathy, normal, as you can see here, using QST will not distinguish between painless and painful neuropathy. So the Germans told us you can't tell if somebody has painful neuropathy by doing QST. But actually what we showed in this study is you can't. Unless the patient tells you, I have painful neuropathy, you're not able to find if somebody has painful neuropathy. But we've made interesting discoveries in Sheffield. Now we can tell if somebody has painful neuropathy without talking to them. So I will show you that in the next 10, 15 minutes. Recently, skin biopsy has been emerging as a diagnosis of neuropathy. And you can see that this skin intraepidermal nerve fibers, this is a study from last year from Düsseldorf, from Danzigler's unit. And you can see there is a difference between normal diabetic and non-diabetic controls. So already there is, by doing skin biopsy, if you can tell if somebody has diabetes. But skin biopsy doesn't tell you between painful and painless neuropathy. So if you use skin biopsy, you cannot tell if somebody has painful neuropathy, painless neuropathy. Recently, though, we have found really interesting discovery, and this was presented in, at the AASD. We're just writing the paper to send for publication. When you do skin microvascular staining in the dermis, you find those with painful neuropathy have a lot more microvascular disease. So it's really interesting, a lot more hypoxia. So these were stained using von Willebrand factor. And you can see these blood vessels, the microvascular proliferation in those with painful neuropathy. But those with painless neuropathy and type 2 diabetes without neuropathy, less. But in healthy volunteers, very little. So healthy volunteers, the least. Diabetes more, but especially more in those with painful neuropathy. Very interesting. Many years ago, we showed that in those with insulin neuritis, if you improve glucose control very rapidly, patients can develop devastating painful neuropathy. In these patients, we found they also develop proliferative retinopathy in the back of their eyes, these patients. We also found a fine network of blood vessels that resemble the new vessels of the retina in these patients. Very interesting. So pain appears to be related to vascular dysfunction in the nerves. This was a young lady who lost a lot of weight because she developed acute painful neuropathy. She was in her 20s at the university. She lost about 6 stones. We still use in England stones. And, 1 stone is 7 kilograms. So she was bones, severe pain, and she had small fiber neuropathy. Touch her feet, terrific allodynia. And she lost a lot of weight, was very depressed. And we took her, and when we looked at her blood vessels on her nerve, you can see so many arteriovenous shunts. We published this in 1996, and it looked completely abnormal. And so nerve hemodynamics may have a role in painful neuropathy. We also did another study where we showed that, in fact, the sural nerve, where if you use spectrophotometer to measure blood flow, those with painful neuropathy had slightly higher blood flow compared to painless neuropathy. So they had also higher oxygen saturation. So the painful neuropathic nerve is damaged nerve, but it is still functioning, whereas a painless neuropathic nerve is a more damaged nerve. So there are some changes that distinguish painful from painless neuropathy at the periphery. Recently, we've been looking at some patients develop devastating complications neuropathy. Others, despite having poor control, they don't develop neuropathy. They're protected from neuropathy. So do genes play any role in neuropathy? So in collaboration with the University of Oxford, we looked at the NAV 1.7 voltage-gated sodium channel, and what we found is this channel is expressed in nociceptors or nerve terminals and amplifies subthreshold stimuli. And if you have homozygous loss of function of these, you can't feel pain. And if you have heterozygous gain of function, you have a condition called erythromelalgia, where you have almost red feet, legs that is extremely painful. So this gene is involved in painful neuropathy. And what we found is these rare variants were more common in those with in those with painless neuropathy. No rare variants found on genetic analysis. But 12 rare variants were identified in the painful neuropathy group. Painful neuropathy is a heterogeneous condition. So maybe genetics plays part in some of our patients. And this paper was published this year in Pain. The other thing is vitamin D. And studies have shown that vitamin D is reduced in patients with neuropathy. But many of these studies did not look at seasonal sunlight exposure, because vitamin D is high in the summer seasons, low in the winter time. They didn't look at activity of the patient. They didn't look at neuropathy assessment, phenotyping the patient, painful, painless neuropathy. And so what we did, and we published this paper this year in Diabetic Medicine, is we found that vitamin D levels are much reduced in painful diabetic neuropathy. What we found is in painless neuropathy, normal levels of vitamin D. But in those with painful neuropathy, the levels are very low, and the lower the vitamin D level, the more severe the pain. The lower the vitamin D level, the worse the diabetic control. The more vitamin D level, the worse the neuropathy. Very beautiful, elegant study. Based on this, we're going to apply for a big grant to see, in fact, if we know that if you replace vitamin D, you reduce painful neuropathy. A paper published last year in BMJ showed a replacement of vitamin D. It's an uncontrolled trial, shows reduction of pain. But does vitamin D, is it involved in the pathogenesis of neuropathy? Very exciting. So in March, there is a call, and my group are going to put in a big grant to do a randomized control trial of the replacement of vitamin D on painful neuropathy, but also we want to see if the improvement in pain is associated with the recovery of the nerve. So we'll do skin biopsy and other things. I'm not going to tell you a bit more because you might apply my grant application. So I'm not going to tell you the whole story. So, but you can see the worse the vitamin D level, the more severe the DN4 score. So very, very, very interesting study. So now I'm going to come to the last part of my presentation. Sorry, it's taken a long time, but I hope it's not boring for you. It's been a long day for you. I'm sorry. Yeah? So many patients come to Sheffield with painful neuropathy. I get patients from all over the world because we have a big lab. We can do all the lab analysis, and so from people come for second opinion, and sometimes you examine them, everything is normal. So they come in wheelchairs, they are very disabled, and when you do clinical examination, everything perfect, they can feel everything, but they tell you, I get electric shock pain, they give you a perfect description of neuropathic pain. So are these people crazy? No, they're not. Because they give you, you can see it in their face, how disabled they are. Then lack of sleep, very depressed, and they've tried all medications, opiates and everything, nothing works. And they are, when you examine them, skin biopsy, everything perfect. And I just want to tell you a little story about this man who lost a leg when he was aged 13. And he lost a leg. He lived a perfectly normal life. So you can shut your ears because you know the story. You've heard it so many times. And this boy was a cheeky boy, in fact. He was a happy boy. Growing, he forgot about the leg, very confident. He lived a normal life. Then in middle age, he developed diabetes, type 2 diabetes. And then he developed
3 minutes.
Neuropathy. Just a few more minutes. Don't stop me. Stories are important for Africans and for Greek people. So he then developed neuropathy in the intact leg. And then he developed painful neuropathy in the intact leg. At this point, he was coming to clinic and saying to me, Dr. Tesfaye, I have pain in both feet. I said, I beg your pardon, with respect. You don't have one leg. But he said to me, I can't draw my foot for you now. This is not phantom limb pain. The man lost a leg and he forgot about it for 30 years. Then suddenly when he developed painful neuropathy, he started to recognize his foot, and he was drawing, he said, I have a lot of pain in both feet. It's weird. So what's happening is the intact leg is sending a barrage of information to the brain. The brain is connected and it's abnormal processing the information, and it's telling the patient he's got pain in a leg that doesn't exist. So it's telling us the pain in neuropathy, the problem is not in the periphery. The problem is centrally. One case, but a very, very interesting information. So we went on to, later on, we also used electrical spinal cord stimulation to relieve neuropathic pain. Now in the UK, this is the last resort. I have many patients who've had this treatment. In fact, now new techniques are coming, very small wires, and you get buzzing sensation in the legs. It's all remote control. At night, they leave it buzzing, and they sleep. And it's a very good form of relieving the pain. But what we found when we did this study in 1996 for the first time in diabetic people was it was effective, but 20% didn't respond, didn't feel anything. So I asked myself, why not? They're not feeling anything. Is the spinal cord abnormal? Before that, spinal cord normal in diabetes. So I came back to Sheffield, and I was starting to ask a question. Here is everything is connected. The peripheral nerves connected to the spinal cord connected to the brain. Diabetes affects the brain. We know it affects small vessel disease. It affects the small the nerves, the peripheral nerves, I showed you, the blood vessels. Why not the spinal cord? The spinal cord is also highly vascular. So many years ago in 1992, in Budapest at a meeting, I was junior doctor in those days. All of us were babies then, the three of us attending the meeting in Budapest, sitting down. And I stood up and I said, there was Peter Watkins, there was P.K. Thomas, the top people in the audience. I said, could DPN, diabetic peripheral neuropathy, be central? So it's my question. And there was deathly silence in the room. And one of them, Professor P.K. Thomas, he's died now, unfortunately, but he said to me, my dear boy Solomon, diabetic peripheral neuropathy has been a peripheral neuropathy for the past 120 years. He wrote 2 volumes on diabetic neuropathy. It will be a peripheral neuropathy for the next 120 years. And upon that, I put my tail between my legs and I went and just took my seat, because these were really eminent people. But ladies and gentlemen, that is the essence of science. Ask an impertinent question, and you are on the way to a pertinent answer. Ladies and gentlemen, particularly the younger members of the audience, if you follow what you've been told, there will be no new discovery. You have to think outside the box. You have to ask questions maybe that are not considered at the time the right ones, but they could be the right ones. So if you have an instinct for something, go ahead and do it, because you might be surprised. You might find something interesting, which is what we did. In Sheffield, and I came back to Sheffield from Liverpool. I was working at the Pain Research Institute, and we measured spinal cord area. And we found that, in fact, published in the Lancet, we found that, in fact, the spinal cord cross-sectional area is significantly reduced in diabetic peripheral neuropathy. It's not a peripheral neuropathy. It involves the spinal cord. Over time, everything starts in the feet, but gradually it's going up and up and up. And then we went to the brain. We published recently in 2014, and we found a bigger study also showed that even in subclinical neuropathy you find reduced cross-sectional area of the spinal cord, but also the gray matter volume in the brain is significantly reduced. We published this in Diabetes Care. So the neuropathic process gradually going to the brain and causing shrinkage. Loss of use in the legs goes over time to the brain. What about pain? Pain is transmitted by these small fibers that you can see. You can't see them on microscope. These are small fibers. And what you get is accumulation of neurotransmitters in the dorsal horn, because they're constantly firing, nearly finished. And these lead to hyperalgesia, allodynia. So pain is transmitted entirely through a different mechanism. Recently, we looked at the thalamus, and what we found is the thalamus is a very important area of the brain. And we looked at the chemicals of the thalamus using MR spectroscopy. And what we found is, in fact, you can see in healthy volunteers and normal diabetics, the chemicals are balanced in the thalamus, N-acetyl-aspartate to choline ratio. In those with painless neuropathy, they're reduced. There's inactivity of the neurons in the thalamus in painless neuropathy. There is hyperactivity of neurons in the thalamus in those with painful neuropathy. When you look at the blood flow in the thalamus, looking at MR perfusion imaging, you find healthy volunteers and diabetic patients without neuropathy have very fast blood flow in the thalamus. Those with painless neuropathy have a delay. And those with painful neuropathy, the thalamus is engorged with blood. So you don't need to talk to the patient. You can actually look at these and say, well, this patient has painful neuropathy. And so the European community gave me a lot of money to look at these in bigger detail, EU grant, but the study is nearly finished now. But I wanted to apply again, but unfortunately there is going to be Brexit. Ladies and gentlemen, some stupid people in England decided to get out of the European community, and I'm going to lose my grant. That's not fair. So the last part of the study I want to show you is resting state functional connectivity of the brain. At rest, ladies and gentlemen, our brain is more active than when we are doing a task. When we are relaxed, and this is a picture taken today, looking at this very beautiful place, your brain is connected beautifully, and you are more creative when you're relaxed. When you're busy doing clinics, seeing patients and you're rushed, you're not creative. Your brain, less part of the brain works. So this creativity, this connectivity, we call it default mode network, or it's called the default DMN fault network. So what we've been doing is we get patients, we ask them to relax, we put them in a scanner, we do functional neuroimaging for 6 minutes. We ask them just think of nothing, just enjoy life, look at that cross, relax. When you look at a healthy volunteer, you see its brain is beautifully connected. Patient with painful neuropathy, there is an overdrive in the pain processing areas of the brain. The anterior cingulate cortex, the insular cortex, these are the emotional pain processing areas. Pain is a sensory and emotional experience, and there is an overdrive of the emotional pain processing areas of the brain that you can see. And so what we do is we combine them together, and we can see what is normal and what is abnormal. And what we found is really, really very beautiful, and it's coming out in Diabetes this in a few weeks' time, is what we found, the anterior cingulate cortex default mode network connectivity relates to pain severity. It gets more connected if the pain is worse. These patients with painful neuropathy, they wake up first thing in the morning. What do they think about? Pain, in big capital letters. The pain takes over their life. I was told today by Professor Diagnoses, in fact, these patients in Greece don't have a very severe pain, I'm told. Not as severe as the ones that we have in England. Could be the Mediterranean diet, I don't know what it is, but in the UK we have patients who have killed themselves because they have this continuous unremitting neuropathic pain. It takes over their life. And it also relates to depression, it relates to anxiety, and it relates to pain catastrophizing. In other words, a 6-minute fMRI scanning tells you about the multimodal aspects of pain. And this is going to be the future. In the future, we're going to look at objective measures, looking at the brain imaging to help us diagnose neuropathy. So the last part of my presentation is looking, if you remember, looking at the homunculus. The foot area in the brain is right on the top. The face is big, hands are really big. They have a big representation on the somatosensory strip. And what we did is we gave pain in the feet. We looked at the brain. Again, this is coming out in Diabetes. And what we did is in healthy volunteers, you give pain in the foot area lights up. Painless neuropathy, the foot area lights up. You stimulate patients with a painful sensate. These are patients who have neuropathic pain, but you can feel when you're touching them. They have irritation when you touch them. But the patients who have painful neuropathy, but who have completely insensate foot, you put a needle through their leg, they don't feel anything. These patients who have a complete numbness and yet pain, it's as if the leg is completely amputated. They process the pain information bilaterally, and it's like that man who lost a leg, but could feel the pain, because he started processing pain in a different part of the brain. So in other words, there is cortical reorganization of the pain processing areas of the brain. Years of not having sensation affects the neurochemistry of the brain. So really this imaging is giving us a new insight into diabetic neuropathy. So the last slide is tissue damage, peripheral damage, leads to nerve loss, atrophy, loss of sensation. But involvement of the small fibers leads to central sensitization, expansion of the receptive field, decreased threshold peripheral stimuli, increased spontaneous activity, hyperalgesia, allodynia. So what you can get both in the same person depending on the degree of involvement of the different nerve fibers. So ladies and gentlemen, I'm not going to talk about management of neuropathy because I think you can ask me questions if you want. Do not ignore painless neuropathy. Painless neuropathy is important also. We need to protect the feet. This lady, do you know how she got this? How do you think she got that? I want one word. Shoes. Ladies and gentlemen, these shoes should not be made for human feet. Maybe for ostriches, you know. Particularly when you have neuropathy, you shouldn't have these shoes. It looks nice though, beautiful, eh? Very beautiful. So painful neuropathy is serious. It causes psychological effect, social impact. A lot of our patients also have all these problems. So unlike chronic back pain, the patient with painful neuropathy endures other diabetic complications. The way we manage them in Sheffield is not just looking at glucose control, pharmacotherapy, lifestyle change. We also do neuromodulation, where we have a psychologist as part of our team. We have a podiatrist, physiotherapist, doctor, nurse, pain specialist, complementary therapies, counseling, behavior therapy, assistive devices for elderly patients. We have multimodal approach designed, tailored to the individual patient. Diabetic peripheral neuropathy is not a peripheral neuropathy. It involves the central nervous system, as I have shown you. Finally, imaging, CNS imaging is giving us a new tool to study the impact of diabetes on the nervous system. I want to thank all my colleagues, my collaborators, including Professor Didyangelos from here. We're doing a joint study now, a joint trial. All the research and PhD students who have worked on all these. I want to finish with one quotation. It's not a quotation from Aristotle or from Plato or Socrates, because these are great heroes. Actually, it's from Stanley Arnold. Every problem contains within itself the seeds of its own solution. Ladies and gentlemen, if we dissect the diabetes conundrum, if we carefully study it, the answers will be there, but we have to find them. Thank you very much indeed.
Solomon, thank you very much for the very interesting and very detailing and inspiring lecture. Δεν συνηθίζεται να κάνουμε ερωτήσεις στην κεντρική διάλεξη του συνεδρίου, αλλά ωστόσο, αν υπάρχει μία ή δύο γρήγορες ερωτήσεις και απαντήσεις, ευχαρίστως. Άλλωστε, για όποιον ενδιαφέρεται, ο καθηγητής S.Tesfaye θα είναι μαζί μας και τον Μάιο, που διοργανώνουμε ένα υψηλό επιστημονικό ενδιαφέροντο σεμινάριο και θα περιλαμβάνει και το θέμα φυσικά του νευροπαθητικού πόνου. Ευχαριστούμε και πάλι και συνεχίζουμε.